My name is Adam Kirking. I'm a Director of Operations with Imperium Health, and I'm excited to be here with you today to talk a little bit about attribution, how to influence attribution, and a topic called green patients, and how we can best support those green patients. Now today we're going to talk about MSSP, that's that Medicare Shared Savings Program, attribution, the things that drive that, and how you as a provider can maybe influence the patients that are attributed to you. We're going to talk about how those patients become attributed to, and even starting to think about how can we best support a slightly different patient a little bit differently to make sure that we're able to really help that patient to thrive, function as independently as possible, and be as happy as possible, most importantly. Then we're going to talk about a group of patients that we'll refer to today as green patients. Now, green patients doesn't mean that they turn into the Incredible Hulk, or that they have a slightly greenish complexion, or that they're Green Bay Packer fans. Green patients, just as in reflection to the care that they receive, is just a little bit different than those yellow patients or those red patients that we had talked about in our earlier webinars. So part of the importance of today's discussion, or why we're starting to think about that attribution focus, is that we're having a new attribution file loaded into Care Journey and ACO Health Solutions as a way to make sure that you're getting the most accurate information available to you. Now, we know that Medicare Shared Savings Program Track 1 ACOs get a rolling or a retrospective attribution that's released on a quarterly basis. And that quarterly attribution can be a little bit frustrating because there can be as much as 10 to 20% change in attribution of those patients quarter over quarter. You may have a patient on your initial list that falls off in the next quarter, but then could reemerge or reappear on the third or second quarter list. So we will do our best to make sure that you have an understanding of what can cause some of those changes and how you as a provider can try and grow that attribution as much as possible. I absolutely view that growing your attribution is one of the best ways to extend the influence of the clinic, and one of the best ways to make sure that it's not a kind of unique one-off MSSP workflow that we have to do. But as we think about a Medicare ACO patient, it becomes almost every Medicare patient, because nearly all of our patients have become attributed to the ACO through a couple tactics that we're going to talk about today, as well as earlier this year. And we know that new lists, or every time we have a new patient become attributed to us, is a new opportunity to learn a little bit more about our patients. Again, one of the biggest benefits to you as a provider for participating in a Medicare Shared Savings ACO is that opportunity to get lists, to learn a little bit more about your patients. And I would really say extend the influence of every provider beyond the walls of their practice. Because we know that if there's always going to be things that happen that kind of make you scratch your head, or that care is delivered outside of the walls of the clinic. So being able to take advantage of data, and turning data into information that you can use to best support your patients in a different way than you could before, is what being in an ACO is all about. So as we get started and we think about attribution files or even all that data, what does an ACO even receive? So we know that on a quarterly basis, Medicare gives the ACO an attribution file. And we know that on a monthly basis, Medicare is going to give the ACO a claims file. That monthly basis is going to be commonly referred to as a Q-assign file, and that claims file is going to be referred to as a CCLF file. We're going to talk a little bit more about both of those on the next page and give you a snapshot for what that looks like. We know that CCLF information, when it comes to us, really must be processed in order to be usable of any sort. And that's one of the challenges for many ACOs as they receive data, is they just don't really have a way to turn CCLF information into data, or from data into information. Because if you have a file full of numbers that doesn't mean anything, you can't do a lot with that. That's not something that a provider can use to really try and transform the care that's being provided to their patients. And we know that Medicare is going to assign those patients to an ACO. And as much as possible, they're going to assign them to a provider, but they don't necessarily tell us exactly which provider they're trying to assign that patient to. And Imperium Health, along with our analytics partners, will do our best to try and replicate that attribution methodology that CMS uses to ensure that every patient is attributed to the right provider, while also being able to take advantage of that claims data coming in, that information that's coming into the ACO, so that we know which providers should be attributed to which patients should be attributed to which providers. Now, on a monthly basis, an ACO is going to receive an example of the thing that comes to the left, or is going to receive a number of those CMS claims line feed data files. This is typically received between about the 15th and 20th of every month, and we know that when we receive them about the 15th, we're usually having them loaded into, or they're usually available to you within ACO Health Solutions or Care Journey by about the 20th. And if we get them by about the 20th, we usually have them loaded or available to you by about the 25th. It takes just a couple days to get them loaded, but it can be a little bit dependent on when we actually get them to you. Now again, the data feeds that we get from Medicare are awesome. However, it really needs to be processed in order to be useful. It goes back to that, what is data versus what is informational? Because having a file full of numbers that doesn't necessarily make sense, while it could be valuable to someone, if it's not valuable at the point of care, it doesn't mean what we wanted it to. And ACOs are also going to receive on a quarterly basis an attribution file. This is going to come in a zip drive that comes to the ACO that includes information related to both expenses, attribution, and then a little bit of background on our patients, like some demographics, some chronic conditions that have been previously coded on our patients, and how can we make sure that we're taking advantage of that information to know a little bit more about the ACO. Now, one of the things that's important to keep in mind about those quarterly files is the majority of the information, especially that cost information, is going to be aggregated at just the ACO level. So I'm not able to tell, did one provider perform a little bit better or a little bit worse than their peers? It's more of a, how did the ACO do, and how did the ACO do compared to other ACOs or other non-ACO, just traditional Medicare patients. So when we get those files that come to us, or when Care Journey and ACO Health Solutions get those files that come to us, they always do their best to try and make sure that a patient is attributed to the right provider. And now we will do our best to try and mimic that attribution process that Medicare uses. And when Medicare is assigning a patient to an ACO, they're going to assign a patient to an ACO that has provided the plurality of primary care services. I'll be honest, that's a mouthful. Essentially, it's who provided the most primary care visits. Your 99213s, 214s, 215s, your transitional care management visits, your annual wellness visits, chronic care management visits. And we'll be sending out, as a follow-up with this, our attribution frequently asked questions, and that's going to have a little bit more exhaustive list of some of those frequently used codes that are going to be helping to drive attribution. And then we know that a beneficiary is going to be assigned at a point in time, but that doesn't mean that they're going to be assigned forever. But we know that one patient can only be assigned to one Medicare Shared Savings ACOs. And we know that the number of ACOs has really grown over the years, and we've gone from just a handful to over 500 Medicare Shared Savings Program ACOs. And that means that within each region, there might be multiple ACOs that are potentially providing care to our patients. So a patient may be attributed to ACO A, so they can't necessarily be attributed yet to ACO B. And some ACOs have a retrospective attribution, and others have a prospective attribution, meaning that those patients are assigned to that ACO for the entire year. In that case, it's very challenging for a retrospective patient to kind of pull one off of that prospective attribution ACO. Now, a couple of the key criteria that Medicare will use to even assign a patient to an ACO. That patient must have had, or that Medicare beneficiary must have had at least 1 month of Part A and Part B enrollment. And they cannot have had any time periods where they had just Part A or Part B. That's not super common, but it's also one of those things that we need to keep in mind of how Medicare is trying to make sure they're assigning the patients to this initiative. Now, a patient can also not have been enrolled in a group plan or those managed Medicare plans. Sometimes you're going to hear this called a Medicare Advantage plan. Sometimes you'll hear it called a Medicare HMO. Essentially, a patient cannot be a part of one of those Medicare group plans or private plans at any point during the year. And a patient, again, cannot be assigned to another Medicare Shared Savings Initiative, or could not be assigned to an end-stage care organization, or to another similar type of ACO program, Medicare ACO program. Patient must reside in the U.S. or the U.S. territories for the whole year, and the patient must have received at least one primary care service from a physician in the ACO. This is one of the things that can be challenging for some ACOs, as they may have a bulk of their care provided by mid-levels or nurse practitioners and PAs. A benefit to our ACO is that because we do have a handful of specialists and great patient-facing specialists, we're able to then use that as an opportunity to maybe include that as the primary care visit to help some of our mid-levels that are part of primary care practices pick up a little bit of attribution along the way. So again, when Medicare is assigning those patients to an ACO, they're going to use a multi-step process to try and make sure that every patient is assigned to the right PCP and the right PCP practice. So Medicare will use this kind of drop-down, or almost like a waterfall approach to assigning patients to an ACO. So first they want to try and assign a patient to a primary care provider. And that's your internal medicine, family medicine, geriatric, peds, general practice, or physician extenders. Now the one caveat with those physician extenders, the nurse practitioners, PAs, and clinical nurse specialists, is that the patient must have seen a physician at some point during the year for a PCP or PCP type visit. And that's going to be your 99213s, 214s, 215s, those office visits. Now after that primary care grouping, so if a patient did not see one of those providers, Medicare will look to assign a patient to a specialist that may sometimes function like a primary care provider. And that could be an obstetrician, cardiologist, pulmonologist, or an oncologist. That's not necessarily an exhaustive list, but that's a pretty good idea for you to think about, okay, which types of providers is a patient likely to be attributed to? Now, a patient really shouldn't be attributed to this next grouping, this kind of interventional or really kind of point of care focused provider like a radiologist, surgeon, interventional cardiologist, or a provider that focuses on a very specific part of the body like a podiatrist. Patient typically is not going to be attributed to one of those providers. Sometimes they may end up assigned to one of those providers on our attribution list. We will do our best to try and make sure that we get any of those shifted around or moved to the correct provider. But again, the focus is really how can Medicare and how can we as an ACO try and make sure that those patients are attributed to the right PCP, and if not the right PCP, maybe the right specialist that functions like a PCP, and hopefully not to those interventional cardiologists or radiologists, because they're less likely to be concerned about some of the quality measures or even thinking about some of the continuity of care components that really help an ACO to be successful. So when I think about the attribution methodology that Medicare is applying, and yes, it's a two-step attribution process where it's did a patient receive a service from a step 1 professional, or did they receive a service from what they're calling a step 2 professional? And the step 2 professional is that second tier of attribution that we had talked about in the previous slide, where it's those obstetricians, pulmonologists, cardiologists, oncologists, those groups of providers that are specialists, but they're likely to treat a patient for more than a month or two. And it really boils down to who saw the patient, primary care versus specialist. When did they see that patient? Because attribution is based on a rolling 4-quarter attribution period. And that might be a little bit before or a little bit after, or if a visit occurred a little bit before or a little bit after that rolling period, it likely is not going to have an impact on attribution. Meaning that right now we're working off the attribution file that came from the second quarter file. And that includes visits from July 1st of 2017 through June 30th of 2016. So if you would have seen a patient in the last 3 months, as we're recording this webinar in September, so that visit might not count, or last 2 months I should say, that July, August, or September visit might not necessarily count towards attribution. And that, would not count towards attribution. And if a patient would have had visits with you prior to June of 2017, or prior to July of 2017, that would not count towards attribution either. So Medicare is most focused on who saw the patients during that defined time period. Now CareJourney is able to take advantage of that additional claims data that we have available to us to try and make sure that we get the patient attributed to the correct provider. But when Medicare is attributing a patient to an ACO, they're looking at visits during that rolling 4 quarters or rolling 12 months. And then who saw that patient? Was it what type of visit was the patient seen for? Was it a PCP type visit? And I use quotations around PCP because Medicare's main focus is the 99, the clinic E&M type visits, as opposed to something a little bit more procedural. So was that type of care provided to one of our patients? And again, really by who and when? So as I'm thinking about those different levels of provider responsibilities, our PCPs are going to be most focused on quality and really trying to drive savings. Also trying to think about annual wellness visits, transitional care management visits, and then trying to do some of those post-acute follow-ups, as well as trying to really manage home health or those extra components of care, and then trying to improve access for our most risky or at-risk patients. Now our specialists, one of our big focuses is going to be how can you kind of best direct those patients back to the PCP? How can you ensure that we're best coordinating with the PCP around any previously performed tests, labs, or follow-ups? And how do we make sure that our hospitalists are also staying engaged in the right way? And that could mean reaching out to a hospitalist, reaching out to a specialist that's not in the ACO yet, but we know is a great team member that we want to continue to work with. So earlier this year, we've started to introduce the idea of red patients, or even thinking about how can we almost stratify some of our patients to put them in groupings that will best support that patient. So we had talked about red patients, which are usually your highest risk or some of your most at-risk patients that are going to have some of your most medically challenging patients in that grouping. That group of red patients is really going to be focused on someone that's using health care different than you would have expected. And those high-risk or those at-risk patients often need a dedicated care plan, direct support, and sometimes even encouragement. It could be as simple as how do we make sure that we're motivating this patient to help them to be successful. Now today we're going to introduce the idea of green patients, and then we'll just briefly touch on yellow patients, but it's the idea of how do we make sure that we're giving those patients that might be needing slightly different levels of care, what they need to really thrive. But also, how do we make sure that we as an ACO continue to receive that information about those patients? Because again, the ACO is an opportunity for you to expand your influence as a provider, to be able to go beyond the walls of the clinic and get information that you may otherwise not have known about, to really impact the health of those patients. So when I'm thinking about green patients, because we know that those red patients are often your most medically challenging, maybe some of your most stubborn, but we know your red patients are the ones that probably need the greatest focus when they're in front of you because they may be the most complex. And now that's not to say that any patient is any more or less important than others. So today we're going to introduce those green patients, and when I think about a green patient, it's often somebody that's going to use a few less healthcare resources. It might be somebody that goes to the clinic a little bit less often. It might be a team member that is not necessarily as likely to actively engage or reach out to their primary care provider. And it may be someone that's not quite as medically complex, but they could be, and they just haven't started using healthcare resources. That person that is starting to become your emerging risk, but they just haven't got there yet. So we know that if we're trying to think about those potential patients that are maybe just not using healthcare quite as much, they're likely to almost fall off the radar, and they don't become as big of a priority for us sometimes. And that's not to say that we're intentionally not making them a priority. They just might not be coming into the clinic as much, or when they come into the clinic it might be a little bit easier, a little bit faster visit. But we know that we want to continue to receive that claims data on those patients. We know that we want to continue to be able to get that extra set of information that we can use as a care team to try and support our patients in any way possible. One of the best ways to do that is to try and make sure that we're seeing our patients at least once every 12 months. That one visit might be all it takes to ensure that the patient stays attributed to the ACO. And again, the more patients we have attributed to the ACO, it makes it easier to ensure that a Medicare Shared Savings ACO patient is just a traditional Medicare patient, or a traditional Medicare patient is just a Medicare Shared Savings ACO patient. And we're going to have almost the same workflow for every patient. We know that the larger our ACO attribution, the more claims data, the more information we're able to get on our patients. And again, our hope is really turn that information or turn that data into information that you can use to impact patient care. We know that that claims data, that information that we have coming to the ACO on a monthly basis, is one of the best ways to really extend the influence of the ACO and go beyond the walls of the clinic to make sure that we're able to make a difference to our patients. We know that staying on an ACO roster is also one of the best ways to ensure that we're triggering some of those CHI or those health exchange notifications. Because if we're not getting those health exchange notifications, that's a kind of a miss. The more data, the more information we have available to us, the better. We also need to make sure that any of those discharge notifications that are sent out, especially as we're using those state repositories, that they're being sent to the right provider, because we don't want to have any potential patient health information leaked to the wrong provider. And keeping a patient attributed to an ACO or staying on an ACO attribution roster is one of the best ways to ensure that we're having the patient sent to the right ACO. And then ACO's minimum savings rate, or the amount of money that an ACO must achieve, is directly impacted by the size of the ACO. Meaning that an ACO of 10,000 would have a lower minimum savings rate, or minimum amount saved per patient, than an ACO of 5,000 or 6,000 in order for the ACO to be able to keep some of those savings that they've earned. And now, certainly our number one priority is how can we improve the health of our patients. But right up there is we've signed up for this program also with the benefit of, if we're able to achieve savings, the ACO is able to keep part of it. The ACO splits those savings 50-50 with Medicare. So we want to make sure that if we create those savings and we do the hard steps that it takes to try and ensure that our patients are getting high value care, that we're rewarded by that by making sure that we position ourselves to be able to take part in those savings and receive some of that money for ourselves. So one of the first things that we're going to do to try and help you engage those green patients is we're going to be sending some lists out to you that are going to have patients that we'd like you to specifically target. Those ones that are either about to potentially fall off your list or potentially de-attribute, or ones that we think maybe could come on your list or could become assignable or attributed to the ACO. That's the way we're going to promote it, is we're going to provide you some information. There might also be some information that's available within your EMR. And as you think about patients that are not in the ACO yet, but you think could be, that could be an opportunity to pull from your medical record to identify, are there patients that maybe we've missed? Now, as you're thinking about identifying and engaging those green patients, I would always say a phone outreach is the best. And that can't be, or it's typically more effective to do a personalized phone call than an automated phone call. And it's typically more effective to do that personalized phone call than a mass mailing. Encourage your patients to come in for their free annual wellness visits. Ensure that as part of that outreach, you're dropping or kind of referring to the provider as much as possible. Dr. Johnson would like you to come in is much more meaningful than community clinic would like you to come in. Sometimes at a larger clinic, it can almost feel like you're a number as a patient, but if it can be connected back to a specific provider, it's going to mean a little bit more to that patient. Always try and focus on keeping the patient healthy as well, because those green patients, the ones that we're about to reach out to, they might be less likely to naturally come into the clinic. And if you contact them for an annual wellness visit, they might say, I'm feeling pretty good, I'm pretty healthy. Focus on how can we make sure that we're able to keep you healthy? How can we make sure that we're able to continue to help you thrive? And we want to make sure that we have the best information for you so that in case anything comes up, we're able to include that with your primary care provider to ensure that they have the best or the most pertinent information. So when we give you that green patient list, it's going to include patients that are both assigned or attributed, as well as patients that are assignable. Now, patients that are assigned or attributed are patients that have received the plurality of PCP services from an ACO provider. These are patients that their costs are going to count towards the ACO's expenditures. Again, essentially all of the patient's costs, other than Part D as in dog or D as in Delta drugs, count towards the ACO's expenditures. And those patients that are on that attributed or assigned list may count towards or may appear on that G-Pro or that quality audit. The assignable patients are patients that haven't yet shown up on the ACO list, but they have been treated by an ACO provider. And Medicare provides that list to us of patients that have been treated by an ACO provider, although they don't identify which ACO provider they were treated by. An ACO receives claims data on those patients, but they don't, and cost information, but the costs don't necessarily count towards the ACO's expenditures. So for those assignable patients, those are the ones that again are not on our list yet, but we do still get claims data on those patients. And a patient may be potentially assignable at one point, but at the next Q assignment file, they may suddenly appear on that list. So our focus for you as a primary care provider, as a provider, is really how can we make sure that we're able to take advantage of the ACO to really extend your influence. We want to make sure that our patients are actively seeing their PCPs at least once a year. As a provider, you may want to consider adding coverage or extending your hours at some point during the day if possible. Now, I'm not asking to redesign your clinic, but the more coverage, the more availability we can make to our patients, the better and the more connected we'll be able to be to our patients. We always want to make sure we're encouraging our patients to avoid using the ED as their source of primary care. It's not the right thing for the patient, but it's also not the care that was intended from an emergency department. We want to make sure that if it's a primary care type visit, that our patients are being redirected to primary care providers as much as possible. And actively contact your green patients. Try and get them scheduled for an annual wellness visit. Try and get them scheduled for a visit yet this year, because the more patients we can get scheduled for visits, the easier it's going to be to try and have an impact on those patients, to grow our influence as an ACO, and hopefully make a difference in the lives of our patients. Thank you very much for your time today. I hope you have a great rest of your day. Hope you've enjoyed the video, and I look forward to the next time we're able to get together. Bye now.